Good afternoon. Dave, please join us here at the stage. I think when our friends outside hear that we started, they will join us. We had really excellent session on image guidance. I think the most expected one from the EBC 2023. And now we go to Medtronic Symposium, and we will really discuss some very up-to-date and future technologies, as well as the results, updated results of EBC Main 3. So we focus, as always, on provisional, and we try to further improve it. Cooperation with the Medtronic and the Visible Heart Lab really helped us to improve several steps of our bifurcation PCI, especially provisional. And one of the lead authors in that process is Francesco. So Francesco, please share your data.
Okay, so we will try to assess the main vessel stent confirmation different stepwise provisional sequences. These are my conflicts of interest. So these are the typical lesions where we know that actually stepwise provisional should be attempted. I mean, there is no measure disease in a branch, but there is tight disease in one, and the branch looks really both big. So I think that these are the typical sequences, conditions where you may consider not just to perform the POT, and consider performing some ballooning after. So what we know and should not forget about side branch dilation. You see that in this simulation that really changed my mind on bifurcation, the fact that you balloon across a stent changes the conformation of the stent itself into the main vessel. And indeed, what we have is a malposition here, and we have this deformation inside. So this is very important not to be forgot, because if we do something like that, we should keep in mind that we should not jeopardize the result we achieved before into the main vessel.
Yes.
So enkissing has been developed to avoid the main vessel result worsening during side branch dilation. So this should be as the polar star here. I want to go on. Okay. What we learned about the limits of kissing balloon inflation? I think that the EBC group, Murasato, showed the fact that by a simple bench test, there is really the possibility to create just selecting long balloons, measure the formation inside the kissing balloon the balloon after kissing balloon inflation. And this is why the French group led by Dr. Finet proposed the post-hypothesis a simple and perfect procedure. It is, I mean, consisting, we know the steps, and it has been presented at EBC as well. However, the bench test comparison with kissing that was indeed tested without the POT on top showed that it is really very effective also not only in preserving the Finet law, but also the flow. And however, into the practice, what was also learned later on, and this is important study by Derimé, the fact that POT seems to be a simple procedure, but it is highly dependent on the position of the balloon we are placing at the carina, and only when the POT balloon has a perfect location, all the benefits of POTS and repot are obtained. And in particular, we had also independent bench test studies performed showing that If you take the risk of being not precise in your POT, going close to the carina, you may really jeopardize the results strongly into the side branch. So this is the problem. And this is why into the EBC main, into the EBC recommendation, you can still find a recommendation about kissing that, coupled with the POT, can really be very effective. This is the sequence of short balloon after POT and repeat POT performed. And you may see that the Onyx stent can really adapt very well, and you will not find a measure oval distortion into the entire stent, and the oval distortion is mainly related in the polygon of confluence. So on top of this, we designed the Krabbe study that was aimed to compare the stent configuration obtained by two different side branch optimization techniques after main vessel implantation, and the sequence were POT, kissing POT, and POT side POT. The technology was the visible art. I think that all the EBC group is exposed to that. And the study consisted into harvesting and the reanimation of the porcine hearts. Then what happened in the beating heart was to perform the 30 PCIs on bifurcation coronary arteries with large side branches. In particular, we selected as entry criteria reference diameter in the side branch more than 2.5 and reference diameter in the distal main vessel more than 3.25. And the sequence was that we performed crossover stenting, then POT was applied, and then there was randomization onto POT side POT or POT kissing POT. In the case of distal rewiring was attempted in both procedures, and honestly, due to the fact that there was also the angioscopy, it was successful almost all the time. And on the opposite, there were, according to randomization, there was kissing or side, and then re-POT was applied with the same balloon in all the cases. So what happened after was the fact that there was the possibility to observe the results by three modalities: independent modality, angioscopy, angiography, and optical coherence tomography. And also we performed in post-reanimation phase micro-CT. The study endpoints were in the entire bifurcation area close to the takeoff, where as the primary endpoint minimum stent expansion at the distal main vessel in both the highest resolution modality that are OCT and micro-CT. And secondary endpoints were minimum stent expansion in the other segments, malposition, stent eccentricity index, and side branch osseous scaffolding length. That is this area where the stent can protrude after our side branch intervention into the side branch. So looking at the target bifurcation, I mean, you really see that they were very comparable to what is large bifurcations in our human practice. You see that proximal main vessel was more than 4.0, the distal main vessel 3.5, and side branch 2.6. So large bifurcation were enrolled, and no other differences in terms of balloons used into the two groups. Side branch optimization followed the practice. The length of the stent was comparable, and also there were no differences in any of the side branch interventions balloon performed. And this is the primary endpoint. You may see that there was no significant difference into all the area, except for the area of the distal main vessel, where there was a significant higher main cross-sectional stent area achieved with the POT kissing POT. So this means that POT kissing POT is associated with better results into the distal main vessel. That is probably related just with the fact that the POT balloon cannot entirely correct the deformation induced by the side branch ballooning, especially when you have large balloons like that. These are the other secondary endpoints regarding the mean stent eccentricity index. There was a difference, but it was in favor of PSP that was confined to the bifurcation core mainly. And regarding the side branch scaffolding length, pot kissing pot seems to be able to stretch much more the main vessel stent, protruding more inside the side branch. This is very important, especially in the case you have some disease that you have to deal with, or you need to implant another stent in that area. And regarding the malapposition distance and area, so all the measures, there was a signal for significant improvement with pot kissing pot. If we look at the results by multimodality image, this is what happens with pot side pot. You have this floating area here that is created probably by the fact that you have induced some modification that is not systematically corrected by the possibility of performing the RPOT. And here is also the micro-CT showing the different scaffolding length inside the side branch that you achieve with the two different modality of side branch intervention. So this is the first prospective randomized trial inside this unique preclinical environment. Bifurcation PCI were conducted with different configuration, despite that this is provisional. And PSP has better preservation of the circularity in the proximal main vessel, especially in the bifurcation core. However, pot kissing pot has better expansion and apposition at the level of distal main vessel, as well as at better side branch scaffolding. So what's next? Honestly, we decided to move forward to the humans, and we are performing the human phase of this trial, exactly the same protocol. Micro-CT will not apply, but we will stop for sure at OCT, and I hope in the future we will have the results. So if we come back to the two cases I opened with, they've been randomized in the trial. This is the patient randomized to pot kiss pot, and this to pot kissing pot, sorry. The results in this patient were fantastic at angiography, fantastic in terms of expansions with the pot side pot. However, you see here at the three-dimensional image that there was a similar aspect of some protrusion of the stent struts inside the main vessel. In the other case, that is really very easily performed following all the steps, you see that there is the central position of this part. So this is really one more the evidence that what we see in the visible art seems to rehappen. We will see if we will have the similar statistical results. However, it seems that the phenomenon may occur during our intervention. Thank you for your attention, and thanks my fellow.
Thank you very much, Francesco. Excellent, and looking forward to listen to your results. Dave, can we now discuss EBC Main 3-year update?
Okay, so I'm going to give you some update on the EBC Main study and a couple of cases if we have time. I'm not going to talk about the results in too much detail because Sandeep Arunathayaraj is going to talk about them in more detail later. Here in brief are the results, and the thing I'd like to draw your attention to is the fact that the revascularization rate at 1 year was very similar, but between 1 year and 3 years in the provisional group there's hardly any increment in adverse outcomes, whereas in the systematic dual stenting group, there's quite a substantial increment. And that contributes to the main, if you like, positive finding of the study, which is a statistically significant difference in TLR rates between the systematic dual, which comes out worse than the stepwise provisional. Sandeep will be talking about that in greater detail. So in terms of conclusions and then impact of this study, Okay, almost twice as much TLR. Crucially, only 20% of patients in the provisional group required a second stent. So all of these patients were patients that the operator was quite willing to do an upfront dual stent strategy. So they're prepared to put in 2 stents, but in fact, when they were randomized to the provisional group, only 20% of them actually needed a second stent. That's a really crucial finding, and it's replicated in other similar studies. So for me, one of the most important messages that I try to get out from this study is that you shouldn't really decide. I mean, I put it slightly kinder here. It's not necessary to decide the number of stents before you start. You could go further, say it's a mistake to decide the number of stents before you start. As Jens Lassen likes to say, he's not here this time, but he will be next time, if you start with 2 stents, you can't end up with 1. So what's the impact of the study? Well, I think EBC Main probably redresses the balance a little bit that we've seen over the last 5 years. For the left main, the more complex intervention has had the upper hand. That's different to the situation in non-left main, where pretty much everything has been consistently shown that there's no systematic advantage for a more complicated strategy. That's not the same in left main, where the DK Crush studies in particular have advocated the more involved approach. And I think we have to question, you know, the aesthetically satisfying treatment has really been in the ascendant. You know, allows the cardiologist to feel jolly clever and, you know, very pleased with themselves. Well, look what I did. It looks beautiful. I've done a fantastic job. But is that actually what the patient needs to have a really good result? I think, hopefully, DK Crush, which was, in my view, prematurely placed into the guidelines as a specific technique, I think it should no longer be specified in the guidelines. And I think if that happened, it would be helpful. And you may wonder, why has Dave got it in so much for DK Crush? It's purely and simply because it's an obligate 2-stent strategy. You start with the cyber. If you look at the thing and say, I'm going to do DK Crush, you are committed to 2 stents from the start. And that, as we've shown, is not necessarily the right thing to do. And actually, for our geography in the EU, very few patients actually meet sufficient complexity criteria. In fact, in EBC Main, I think the definition 2 criteria was only 5%, slightly less than 5%. So I think we should pause again to think, is the aesthetically satisfying stent result at the time the one that gives the patient the best outcome? And very commonly the answer is no. And we should also think, as we are thinking, if 1 stent may be better than 2 stents, all other things being equal, then could it be that no stent is better than 1 stent? So that'll be roll on EBC DCB. And if I have a couple of minutes, I have a couple of cases to show you. These, you know, there's selection bias going on here. I accept that, but these are 2 cases. So 78-year-old man with a new diagnosis of lymphoma, and he's anemic. And you can see quite a messy angiogram with, he's getting a lot of angina, at rest, has come into hospital. You know, you could look at this fairly ugly angiogram and think, oh, okay, and start planning in your mind some complicated strategy. But, you know, if you just take these things stepwise, systematically, step by step, and stop when you've got a good result, you can surprise yourself. So what we did in this particular case, he's not trying to get off the table. He's got intractable hiccups from his lymphoma. What we did, in fact, in this case is he had a drug balloon, as I recall, to the mid-LAD, and he had predilatation from the left main into the obtuse marginal. It's not a traditional direction, but in this case, it was probably the right one. Stent, pot, and now I would do the pot puff, actually. I rather like that. I would try that here. Result, finish. Back to the ward, And actually, he's been fine since. So, you know, complicated anatomy with a fairly simple solution. And here's another one. Okay, it's going to be broadly along the similar lines. Here we've got quite a complicated, possibly trifurcation-ish type anatomy, some calcification. This patient has treatment to the proximal LAD and then the LAD back into the left main, has proximal optimization, and then, oh, okay, we seem to have lost our intermediate, or whatever you want to call that vessel, very high diagonal, and the circumflex. Patient doesn't like it that much. And you could immediately be thinking, oh, stent, but just take it step by step. So pot, rewire, kissing, and okay, great, we're doing better. The circumflex is still lost, but we've got the intermediate now. Okay, same again, rewire, kissing, and actually that was all that was needed. And that was in 2016, and he's been fine since. So, you know, sometimes we should do less rather than more, and trust also partly to the magic of the human body, which is nearly always greater than the magic of the interventional cardiologist. Thank you.
Fantastic. I think you should do it in front of the FDA in order to help our colleagues in US to use bifurcation provisional more. Now we go to new technologies. Dr. Hikichi,
yes.
You pre-recorded your presentation or?
Already.
Yeah, okay. So let's listen to role of physiology using the CutWorks in bifurcations.
Good afternoon, everyone. I will discuss about FFRangio. This is my disclosure. In Japan, wire-based FFR was approved for insurance in 2016, and since then, the use of wire-based FFR has gradually expanded. From 2018 onwards, providing myocardial ischemia became a prerequisite for performing PCI on CCS. From that point, the number of PCIs has been gradually decreasing. At the same time, among the devices used to evaluate myocardial ischemia, the frequency of using wire-based FFR in particular began to increase significantly. Wire-based FFR is gold standard. Meanwhile, coronary CT machines are widely available in Japan, and introduction of the FFR CT utilize their capability is also being promoted. In this context, my hospital chose FFRangio, which was approved for insurance at the end of 2020. Wire-based FFR has several challenges to address. First is the cost, as drug per wire and load are required. The procedure time for the diagnostic catheter is extended. In some regions, measurement can be challenging, and in case of complex lesion morphology, the frequency of complication became a concern. CT-based FFR also has a challenge. First, a volume of contrast agent. Caution is necessary depending on the renal failure. And what I'm concerned about is the reduction in the training opportunity for young doctors due to the decrease in catheter case. If appropriate angiographic images are obtained, FFRangio will provide FFR value. In practice, there are 4 steps to derive result, And while I don't fully understand all these steps, by sending appropriate tri-directional angiographic image to the device, and skilled radiological technician will analyze them. Regarding reliability of the result obtained, many credible reports are available. High correlation between wire-based FFR and FFRangio have been shown, with high sensitivity and specificity and good overall accuracy. In research from the Gifu Heart Center in Japan, similar results have been obtained as in preceding FFR studies. In the group with FFRangio positively who received additional PCI, and in the FAME2 group with FFR positively who received additional PCI and medical treatment, it can be seen that the subsequent outcomes are very similar. I have listed some requests here, but young doctor quickly memorized them, and high-quality image can be obtained. We minimize contrast agent use during exam by creatively adjusting angle and using an automatic injector. The first case is simple RCA. The total amount of contrast was 8 ml. Both wire-based FFR and FFRangio were performed, and both yield reliable results. Moving on to bifurcation. It is a lesion at the bifurcation of the LAD and the diagonal, and it appears there is no lesion in the diagonal ostium. Regarding long lesion of the LAD, severe ischemia was confirmed in both the LAD and the diagonal after measurements were taken using the both wire-based FFR and FFRangio. I believe what everyone is particularly interested in the post-treatment value. In this case, we use OmniWire to check the FFR value for the side branch after main vessel stenting. After the stent implantation into the main vessel, stenosis appears at the side branch ostium due to carina shift. In this case, there is a discrepancy between the result of wire-based FFR and FFRangio for the side branch. The reason is not clear, but it might be due to the influence of the FFR wire in the side branch. Let me present another similar case. The diameter of the side branch is not large, but it has a broad dominant. The strongest stenosis is right after the bifurcation in main vessel, and FFRangio evaluate has a positive for the main vessel and negative for the side branch. The same result was obtained with wire-based FFR. It is a diffuse region, and two stents are placed. After treatment, good blood flow is maintained in both the main vessel and the side branch. In this case, we measure the value by threading the FFR wire toward the side branch. First, the need of the side branch expansion was confirmed by FFRangio. Then wire-based FFR was added, and both were similar negative. If these utilities are proven, it could become a groundbreaking method for decision-making in bifurcation treatment. Lastly, let me point out that the current version has its limitations. Stenosis is observed in the left main shaft and the middle part of the LAD. He is asymptomatic, and I would really like to know whether there is ischemia or not. This is another angle. FFRangio recognized the presence of the stenosis, but was negative. For caution, wire-based FFR was performed, and it turned out to be clearly positive. Ad hoc PCI was performed to verify the region of the left main shaft, and severe stenosis was confirmed with an IVUS image. You should be aware that the current version of FFRangio does not support left main. This is my conclusion. I expect FFRangio to be especially useful for evaluating ischemia in main vessel and side branch before and after coronary bifurcation treatment. While there are still limitations, the speed of version update is fast, and I anticipate it to become a valuable adjunct for coronary bifurcation treatment in the near future. Thank you very much.
Thank you to all three of you. Dr. Hikichi,
Yes.
how do you see in the future use of this technology in bifurcation treatment, pre, during, and evaluation of the jail side branch, or you still believe that impact of main vessel disease may impact also the numbers that we achieve in the side branch?
Yes, exactly. I think the total contrast, and we usually use the bibrand machine. The total contrast left coronary artery has only 10 cc additional volume, and after then we check the main vessel and the side branch. So especially the after treatment, as implanted main vessel, we can check to use the side branch. We have better expansion or not. It is a very important point.
Okay, thank you very much. So on behalf of the EBC, we really thank Medtronic again for setting up this symposium and for continuous cooperation with the Visible Heart Lab, and also for allowing us to use new technologies. Provisional remains our gold standard, but we still identify spots to be improved, and pot side pot versus pot key spot is probably one that is left unclear, and I hope that we will be able to get one more answer in our consensus. And they, of course, at the end, thank you very much for putting wording that we will use in the next couple of months, trying to convince people that EBC Main at 3 years really shows a wonderful trend towards the reduction in events. Thank you very much all.
Thank you.